Welcome everyone, and thanks for joining us today. Today we are going to talk about Lambert-Eaton myasthenic syndrome, also known as LEMS, and Myasthenia gravis, also known as MG. We are going to talk more about these two neuromuscular conditions, knowing the difference and getting a correct diagnosis. We are excited to have you with us. Well, I'm Samir Makwan. I'm a neuromuscular neurologist practicing in Greater Palm Springs area. I've been practicing for almost 11 years, and I've been taking care of patients with Myasthenia gravis as well as Lambert-Eaton myasthenic syndrome. So what are LEMS and MG? As we did talk earlier, Lambert-Eaton myasthenic syndrome and Myasthenia gravis, they both are autoimmune disorders, and they both are rare disorders. These disorders do affect the communication between nerve and muscles, and they are caused by immune attack at the neuromuscular junction. So what the neuromuscular junction is, that it is the connection point between nerve and a muscle. And we are going to talk about that a little bit in detail in next several slides. On a basic level, the difference between Lambert-Eaton myasthenic syndrome and Myasthenia gravis from a biologic perspective is where the autoantibodies are targeting. Remember, the neuromuscular junction is the connection point between nerves and muscles. And synapse is the space between the nerve cell and the muscle cells. Lambert-Eaton myasthenic syndrome is caused by antibodies that attacks the presynaptic calcium channel, or on the site of the neuromuscular junction synapse that does send the messages. On the other hand, the Myasthenia gravis is caused by the antibodies that attack the postsynaptic acetylcholine receptors on the side of the neuromuscular junction synapse that receives the messages. Because they both are caused by different mechanisms in the body, each condition should be managed differently. Therefore, it is extremely important to get the right diagnosis. Please note that Lambert-Eaton myasthenic syndrome is rarer than Myasthenia gravis. So we are going to review key terminology here. Autoimmune disease. What the autoimmune disease means that when the immune system in the body goes haywire, that's when the body's own immune system attacks the healthy cells in the body. So that's what's the general terminology is autoimmune disease. Another terminology that we have talked about is the antibodies. Both of these disorders are antibody-mediated disorders, Lambert-Eaton myasthenic syndrome and Myasthenia gravis. So these are antibody-mediated disorders, and it is important to know what the antibodies are. And pandemic has taught us quite a bit about the antibodies, that we all need antibodies, what they do, fight against the foreign objects such as viruses, bacteria. When the immune system in the body goes haywire in conditions such as LEMS and Myasthenia gravis, those are autoimmune conditions, instead of attacking against those foreign objects, they do attack the body's own cells. And in this condition, they do attack at the nerve level, at the nerve terminal, as we did talk earlier, as well as at the muscle membrane. The most important aspect that we will be talking, or we have talked about, is the acetylcholine. What is acetylcholine? Acetylcholine is a chemical that we have in our body, and acetylcholine is responsible for muscle contraction. I'll bring one terminology. When the body sends signals to the muscle, if we want to perform certain activities, such as if we want to close eyes, or if we want to raise arm above the shoulder level, or if we want to go, or if we want to get up from the chair, the brain sends the signal via nerve to the muscle. And there is a connection between nerve and muscle, and we call it a neuromuscular junction. And from nerve terminal, the chemical which is released is the acetylcholine, and acetylcholine is released from the nerve terminal. And then it goes through the synapse, and then it goes to the muscle membrane, and it gets into the muscle, and that leads to the muscle contraction. So this is the very important chemical in the body, which is responsible for muscle contraction, which is under the voluntary control when we want to perform certain activities. So that's the basic concept of the acetylcholine. Neuromuscular junction is the connection point between nerve and muscle cells, as we did talk earlier. Synapse is the space between the end of nerve cell and the another cell. Presynaptic level, presynapse, which is the neuron that delivers the message across the synapse. So that does deliver the message, and postsynaptic is the neuron that receives the message across the synapse. So these are certain terminology. So there are common symptoms that leads to the misdiagnosis. And Lambert-Eaton myasthenic syndrome has very, very common symptoms. And the reason why the condition Lambert-Eaton myasthenic syndrome can be misdiagnosed, because many physicians are not familiar with it, or they have not seen the folks with Lambert-Eaton myasthenic syndrome, or they have not come across in their patients. And as a result of that, unfortunately, more than 50% of folks of Lambert-Eaton myasthenic syndrome may be misdiagnosed or undiagnosed, because the symptomatology, symptoms are very common. And more than 1/3 of the Lambert-Eaton myasthenic syndrome patients have a misdiagnosis, or they were diagnosed with Myasthenia gravis at certain point. And I'm going to talk about a few of the symptoms, like drooping eyelid, that can be seen with a variety of other disorders, such as muscle weakness in the arm and legs, double vision, trouble swallowing, and trouble speaking. So these are the common symptoms that can be seen with variety of other disorders, variety of other common presentation that physicians do come across, and that's what leads to misdiagnosis or not being diagnosed. Because the symptoms are so similar, how do we tell the differences? What do we look for? Lambert-Eaton myasthenic syndromes usually affects the lower part of the body first, causing leg weakness, and then maybe spread up the body, causing arm weakness, dry mouth, and vision issues. On the other hand, Myasthenia gravis affects the face and neck muscles first, causing difficulties with speech, swallowing, and vision, and then moves down the body. In addition, 90% of MG cases include early eye involvement versus 5% of folks in Lambert-Eaton myasthenic syndromes have eye involvement. So this could be drooping of the eyelid, double vision. Myasthenia gravis cases generally do not include autonomic symptoms, where most cases of Lambert-Eaton myasthenic syndrome include some sort of autonomic dysfunction. Autonomic functions are those things the body does automatically or without you thinking about them, like breathing, digesting, swallowing. So most cases of Lambert-Eaton myasthenic syndrome do include some sort of autonomic symptoms. Lambert-Eaton myasthenic symptoms, specifically muscle strength and tendon reflexes, may improve slightly or temporarily when exercises. And as the exercises continue, it becomes weak. On the other hand, in folks with myasthenia gravis, the symptoms do get worse with exercise right away and keep getting worse, confirming a diagnosis with either Lambert-Eaton myasthenic syndrome or myasthenia gravis. They both are typically diagnosed through at least one of the following methods: physical examination, that's very important, first and foremost part. Number two, it's a blood test to check for antibodies. And the third thing is an electrodiagnostic test. While the test may be the same, doctors are looking for different things to happen or testing for different antibodies. The presence of autoantibodies to voltage-gated calcium channel can be found in up to 90% of patients with Lambert-Eaton myasthenic syndrome. In patients with generalized myasthenia gravis, the vast majorities of patients have acetylcholine receptor antibodies, and there are a few other antibodies that can also be present. And the third thing, in an electrodiagnostic testing, doctors record electrical activity and look for certain abnormal pattern during repetitive nerve stimulation. Upon stimulation, people with Lambert-Eaton myasthenic syndrome may have improvement temporarily, only for the muscles to weaken again as it continues. So folks may have temporary improvement with the electrical testing, specifically the repetitive nerve stimulation test. On the other hand, in patients with myasthenia gravis, we do not see this temporary improvement. So the importance of right diagnosis is extremely, extremely important. The sooner you know what's causing your symptoms, the sooner they can be treated appropriately and with the right technique. The right treatment and disease management techniques can potentially lead to fewer symptoms and generally feeling better and being able to do more. In people with Lambert-Eaton myasthenic syndrome, about 50% of cases are caused by cancer. So screening is extremely important. For some patients, Lambert-Eaton myasthenic symptoms are an early warning sign, and that may help to save their lives. So now we are going to talk about patient experiences, and we are very grateful that we do have two patients available. The first of all, Jennifer Walrat-Grossam, she's available. She's diagnosed with myasthenia gravis, and we are going to talk about her journey. So I would like to welcome Jennifer, who was diagnosed with myasthenia gravis in 2019. Welcome, Jennifer.
Thank you, Dr. McQuan.
Thank you. Thank you. So tell us about when you first noticed something was wrong.
In the fall of 2018, I was doing quite a bit of yard work, and my arms and hands kept cramping up, and I developed weakness in my arms, and that gradually spread to my shoulders. And in the spring of 2019, I just didn't feel right. And because I am a doctor, I ordered food sensitivity testing on myself to see if I was reacting to something in my diet. And I made some pretty big changes, and I didn't feel any better. And I gradually developed more weakness. I used to run 5Ks and 10Ks for fun, and I had to start walking. I became very heat sensitive. And then in the fall of 2019, I could no longer lay on my back to sleep because I couldn't breathe. And over the course of just a few weeks, I started to have shortness of breath just talking.
Oh.
And I became extremely ill within the course of days.
Oh, okay. So you're a doctor and you were sort of aware about the situation, but what steps did you take?
Well, I had actually run a myasthenia gravis panel on myself, and it came back negative. And at the time, I had no idea there was such a thing as seronegative myasthenia gravis.
Sure.
But as I became critically ill, my husband took me to the emergency room, and they told me I had anxiety because my pulse oxygen was 99, but I was gasping for air. I couldn't even talk. And they sent me home, and I was pretty much scared out of my mind. And the next day we called the rescue squad because I couldn't breathe. And they they gave me a nebulizer treatment, which did calm me down a little bit, but that was because I slowed my breathing down, and that was on a Saturday. On Monday, I told my husband that I had written a goodbye letter to he and the kids because I knew I was going to die because I couldn't breathe. And that night, I remembered a neurologist I had met 20 years ago. And the next morning, I called his office. I was able to talk to the triage nurse who got me in to see a nurse practitioner that afternoon. And as she was examining me, she was extremely worried. And she went and got a neurologist who happened to be the same man. And he immediately told my husband he either had to take me to the emergency room and he would have everything all set to have me direct admitted, or he was calling a rescue squad. And he saved my life.
Right. Okay. Okay. So how are you feeling now after you've been on a treatment plan?
Well, myasthenia gravis has very much impacted my life. I'm a chiropractor, and I used to see about 200 patients a week, and I have had to give up my career. I am better now than I was even a year ago. I've been through many different options and courses of treatment, and I feel I'm about 50% of my normal, but my arm weakness is terrible. I can't put dishes away in the cupboard. It's hard to wring out a washcloth, but at least I can walk now. I used to run and bike and kayak and hike, and I literally can't do any of that anymore. But I walked the dog 2 miles this morning, and I didn't have to rest for 2 hours after like I used to.
Yes.
So I am hopeful that I will continue to improve.
Yeah.
I'm on 5 medications, and I get infusions about every 10, 11, 12 days. So I'm still very significantly medicated at this point.
Yes. 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 It has impacted your life significantly. I was wondering, how were you diagnosed officially? I understand, yeah, the test was run and it was negative. Have they done any other test, as we did talk, such as, yeah, the electrical test or, yes?
Yes.
Sure.
When I was in the hospital, my first trip to the hospital, when they saved my life, they did run even more extensive myasthenia gravis tests
Sure.
and sent them to the Mayo Clinic. And my second day in the hospital, the neurologist that I was seeing did the repetitive nerve conduction velocity test on my thumb.
Right.
And it actually came back normal, but I had a pretty significant dose of an immunoglobulin the day before, and I was on steroids. And he has continued to treat me, and he is 98% sure that I'm seronegative myasthenia gravis because I have responded. I have had a thymectomy.
Right.
And he is hopeful that I'll go into remission within 1 to 3 years of having that thymectomy.
Very good. Very good. Well, yeah, thanks for sharing that experience, because getting the repetitive nerve stimulation test is not easy. It can be, yeah, it can be, yeah, the painful, cumbersome. So what advice would you give someone who is searching for a diagnosis?
Well, I think one of the most important things is to keep a journal, and literally to include everything. I mean, I went back and wrote down everything going back to 2018. And I also keep a big spreadsheet with about 30 items on it. And I document every day how I'm feeling. And that had allowed the doctors to see what meds were working and what weren't working during this time. And I just think it's great for all patients. The more information you can provide to a doctor, the more they can help you.
Right. Okay. Well, thank you, Jen, for sharing your story and experiences with us. You are a powerful advocate, and your experiences will certainly add others as they navigate their diagnostic journey and search for an answer. So thank you again.
Thank you very much, Dr. McLean.
Okay. All right. Thank you. Okay. All right. I would like to introduce our next guest patient, Tasha. Welcome, Tasha. Thank you for being here and sharing your experience with us.
Thank you. Glad to be
Thank
here.
you. Yeah, thank you. So, like Jen, you had a difficult and long diagnostic journey.
Yep.
Tell us a little bit about that and how your symptoms started.
Sure. Initially, I started symptoms in fall of 2012. I actually had a sudden bowel obstruction October 2012 that spontaneously resolved. And about 2-3 weeks after that, I developed bilateral lower leg tingling numbness, weakness, inability to stand from a seated position, fatigue. So I went to my primary care that December, and then who referred me to ortho, possible muscle biopsy. Did not feel that it was needed at that time. So sent me to a neurologist, had multiple workups done, and it took me about 7 to 8 years to finally get a diagnosis.
Okay, yeah, that's a very, very long time, right? So uh, you were sent for a lot of tests,
Yes.
right?
Yes.
Yeah.
Yes. I've had multiple MRIs, basically looking for MS. I've had so many EMGs I can't even tell you. I've had echoes and blood tests, and I mean, just so many tests that they were always coming inconclusive, or they couldn't find anything. I did have multiple of the calcium channels done. I've had actually three.
Three.
Three. The very first one was slightly positive back in 2014,
Okay.
but the EMG was negative. And then I've had my next one I had was July 2019, and then another one November 2019 that was even higher.
Okay. So yeah, it took 7 to 8 years. The symptoms started back in 2012. So
Yes.
yeah, that must have been incredibly difficult. So
Yeah.
was there something you did which you felt really made the difference in finally getting a diagnosis?
It was really I kept going to the same facility that's very well known, and they kept coming up with nothing despite me getting worse. I mean, even after I had respiratory failure and was on oxygen for 6 to 8 months, they still were not coming up with a diagnosis. And finally, when I had worsening in April 2019, I made a decision to leave and find different specialists. And it wasn't until that point that I finally got my diagnosis. I feel that if I hadn't advocated for myself and made that decision, I probably would still not have a diagnosis.
That's a powerful story. How do you feel now? Now you are on a treatment, you are on a platform therapy.
Yeah.
If you can share a
Sure.
little bit about that.
I feel hopeful that I'm going to continue to gain and continue to improve. Even though I may have slight ups and downs, I'm feeling more getting closer to my old self than I was prior. And so I have that hope that, you know, my story is going to continue, and I'm going to continue to improve, and my chapters are going to have better stories, and that this is just the beginning. So it's kind of how I feel, that though I may have to do all these different treatments and infusions and that, it's getting to me where I need to be, and finding a new, better self.
All right, again, yeah, thank you. Thank you for sharing such a powerful story. We appreciate your courage and willingness to share your experience. So
Sure.
thank you again.
Yeah.
So those are two powerful stories, and I would like to thank both Jen and Tasha for sharing uh, the experiences. So talking to your doctors, there are several points that I would like to talk today. If you think you might have a neuromuscular disorder, speak with a neurologist or a neuromuscular specialist. Because oftentimes, so many of those symptoms can be seen in a variety of other disorders, and the fatigue, which is very, very common with a lot of other disorders. Trouble with getting up from the chair, which is quite a bit common, but if you feel like, or when you are educated enough with neuromuscular junction disorders, please do not hesitate to bring those complaints to your primary care physician, who can send you to the appropriate neurologist or a neuromuscular specialist. As I've said, that the symptoms are very common. They can be seen with a lot of other disorders. So be specific about how your symptoms affect your activities of daily living. As we heard powerful stories from both of our patients, the disorders have impacted their quality of life enormously. And what happens here with the neuromuscular junction disorders, that they can be fluctuating. That's a hallmark. Folks can have good time and bad time, good hour and bad hour, good day or bad day. But just come prepared to the appointments with notes and questions. And daily journal, that's keeping a daily, that's very, very important. As Jen mentioned, that tracking the symptoms, and then if you have a daily journal, how you've been doing, that's enormously helpful. It does help you remember during your appointments. It does show progression over the time, and clinicians could identify trends or patterns. And knowing test is extremely important. Voltage-gated calcium channel antibody, in case of Lambert-Eaton myasthenic syndrome, it's a very quick and very sophisticated blood test. And knowing the test is important. And as I mentioned earlier, that this is the rare disorder, and oftentimes the clinicians have not come across with that. So physicians are busy taking care of a lot of other common disorders. So this may not come across, but if you, being a patient, you can be your best advocate, and you can always request a test, and it can be run very easily. So I believe, yes, we have few questions that come in for myself and our participants during the discussion for both Jen and Tasha. Would you mind joining me for a quick question and answer, Tasha and Jen? Thank you. Thank you. Okay. Yeah, what I see, the first question I think that has come for me, is it common for both myasthenia gravis and Lambert-Eaton myasthenic syndrome patients to have other autoimmune diseases? Yes, it is common. Folks with one autoimmune disorder have a higher propensity to have another autoimmune disorder. So I have a question for both of you, Jen and Tasha. Did either of you have difficulty explaining your symptoms? And if so, how did you overcome that? So either one of you. Yes, thank you.
My symptoms were very consistent. Each time it would return, it was the same symptoms always, and in the same pattern. You know, the legness, tingling, numbness, weakness, difficulty standing, and then it just progressed year after year with shortness of breath, tachycardia. I mean, it just seemed like it was the same symptoms, but it kept adding on with each basically episode or relapse. It just kept adding, and then now having vocal cord dysfunction now. So it just kept adding. So.
All right. Okay. Thank you. Thank you. Jen, would you like to say something?
Sure. In my scenario, mine was a gradual progression of shortness of breath. Shortness of breath with going up the basement stairs or not being able to run anymore. I had to walk. And then being short of breath when I was treating patients, and then shortness of breath with talking, and then shortness of breath at rest. Mm-hmm. So mine was over the course of a few months, a gradual progression of that shortness of breath. And throughout that time, I was experiencing weakness in my arms and shoulders, not really my legs at that point. And if I hadn't advocated for myself and gotten myself in via that triage nurse at the neurologist's office, yeah. I was hours away from crisis and ventilation.
Yeah.
So.
Okay.
And I had Graves' disease 14 years prior. And I didn't know there was a connection between Graves and myasthenia gravis until after the fact.
Sure. Well, thank you very much for sharing that. And yes, and you kind of solidify my answer to the first question. So the second question is for myself. If a patient is diagnosed with myasthenia gravis, what advice do you have for them? The advice, as we have talked today, yes, keeping a diary, tracking your symptoms, and you can be the best advocate for yourself. There are several tools available. This is a very treatable disorder. One does not have to live with that, although it does impact one's quality of life enormously. But my advice, or I always say that to the folks with myasthenia gravis, that before 1960, the mortality rate was 30%, more than 30%, and therefore the name came out as a Gravis, the grave-like disorder. It's not the case anymore. We do have a lot of tools available here in 2020. The mortality is less than 5%, and according to some reports, it is less than 1%. So it is not the grave-like disorder anymore. We do have several tools that we can utilize to help one's quality of life. So that's what that's the advice I would give. I think that the fourth question that I see here, I think that's for myself. Do myasthenia gravis patients have a risk of cancer? Not usually. Folks with myasthenia gravis do not have the risk, but the folks with Lambert-Eaton myasthenic syndrome, yes, there is a risk. The 50% of folks, as we did talk, they've been they're diagnosed with the cancer. So that's the answer. I think the fifth question is coming for both the Jen and Tasha. Which doctor would you say has been most helpful in your personal journey? So either one. Okay. Sure. Jen.
For me, the neurologist, yes, without question.
Thank you. Thank you. Tasha, would you?
I would say my neuromuscular specialist, but how I actually got there was from my from my laryngeal specialist is how I got to that specific neuromuscular specialist. So.
Okay, very good, very good. Okay, thank you.
Mhm.
And looks like the sixth question, I see, what do you recommend for both myasthenia gravis and LEMS patient for managing their disorders? Uh, as I've said earlier, you can be your best advocate, and we do have several tools available, and we can utilize that. Again, on one hand, we do have a science of medicine, we do have our data, we do go through the clinical trials, we do practice evidence-based medicine, but here managing neuromuscular junction disorders such as Lambert-Eaton myasthenic syndrome and myasthenia gravis, the art of medicine plays very important role because each individual is different and each individual has their own different manifestations. So tailoring the treatment is very important. And again, this is like the partnering, because this is what I tell my patient, that this is a journey. We are here with you, and I partner with you for this, for the management. And these are treatable condition. We can help you for a lot of your symptoms. It is not going to be eradicated, unlike infectious diseases or some other condition. This condition is not completely going to go away, but we can do a lot to help you out. And we need cooperation from both sides. And as a clinician, I always tell my patient that this is a journey, and we are going to be together. And I am partnering with you, and that's very, very important aspect between the physician and the patient, and then we can go from there. It looks like that is our last question. I would like to thank both of our guest speakers, Jen and Tasha, for sharing their experiences with us today. If you would like more information related to this presentation, you can follow LEMS Aware at the social media handles noted on the screen. Thank you all for joining, and we hope you found the discussion valuable. Thank you very much.